Welcome to the deep dive. Today, we're really tearing into some material focused on something absolutely fundamental in healthcare, perioperative care.
Right, that whole journey a patient takes for surgery.
Exactly, from start to finish. And our mission here with this deep dive into this study guide is really to pull out the crucial concepts, highlight the essential safety points, and, zero in on the vital roles nurses play.
Get you right to the core knowledge quickly.
That's the plan. We want to show you what's most important and maybe even some surprising angles on this whole process.
Yeah, things you might not think about. Think of it as like the insider's guide to how safety and coordination work behind the scenes for surgery.
Okay, let's jump right in. So this guide breaks the whole perioperative journey down into three main phases.
Right. First up is the preoperative phase.
Yeah.
This kicks off the second the decision for surgery is actually made.
Okay,
And it runs right up until the patient is transferred into the operating room.
got it. In phase two.
That's the intraoperative phase. Starts when they hit the OR and lasts until they're admitted into the PCU, the post-anesthesia care unit.
PPCU, right. And the last one.
Finally, you've got the postoperative phase. Begins in PCU, covers the whole recovery time, right through any follow-up evaluations.
So it's a continuum.
Exactly. A continuous process, and each phase has its own, critical safety stuff to focus on.
Let's stick with that preoperative phase for a bit then, because it sounds like a lot of crucial groundwork happens there, especially safety. And right at the top seems to be informed consent.
Oh, absolutely. Informed consent is, well, it's non-negotiable. It's the patient's right to really understand the procedure.
Understand everything.
Yeah, the risks, the benefits, what other options there might be, and then agree to it freely. It has to be a genuinely informed decision.
And the nurse's role here, it's interesting. They don't explain the surgery itself, right? That's the doctor.
Correct. The physician explains the details, but the nurse, they're a critical safety check on the whole process. Well, they verify the surgeon did have that talk and that the patient signed the form. They can often reiterate information, maybe clarify things.
Okay.
And this is key. If the patient still has significant questions, the nurse has to stop everything. Call the surgeon back in.
Ah, okay. They can't just proceed.
No way. And they also make absolutely sure that form is signed before any medications are given that could make the patient drowsy or, impair their thinking.
Like pre-op sedatives.
Exactly. So the nurse is really the patient's advocate at that moment, and they act as a witness to the whole consent process.
So it's much more than just getting a signature. It's about checking, understanding, checking the timing. The guide mentions specific things that make consent valid.
Yes. It has to be given freely. No pressure, no coercion at all.
Okay.
The patient needs to meet age and competency rules, usually 18 or emancipated, and mentally competent to grasp the info.
Competent
Meaning they understand what's being explained. They have to be informed by the physician about risks, benefits, alternatives. And it must be witnessed by professional staff, like the nurse.
Which naturally leads to thinking about when someone can't give valid consent.
Right. The guide's pretty clear on this. If a patient has cognitive issues like dementia, delirium, maybe active psychosis for mental illness, or if they're intoxicated, alcohol, drugs, or even other neurological problems, temporary or permanent, that stop them from understanding and deciding properly, they just can't give meaningful consent in those states.
You really see the safety net there. The guide explicitly links that nursing role in consent directly to patient safety.
It's a crucial checkpoint.
Ensuring understanding and competency right before you give meds, which ties right into those patient medication rights.
Exactly. It's layered safety. And those medication rights, they're just fundamental. The guide lists 9. Right patient, right medication, right dose, right route, right time.
The classic ones.
Right documentation, right reason for giving it, checking the right response afterwards, the patient's right to refuse, and providing the right education. Standard checks before any med, especially important pre-op.
Okay, shifting gears slightly, but still pre-op labs. The guide emphasizes specific pre-surgery lab work. Why these tests?
Well, these labs give us a snapshot of the patient's baseline, their physiological state, and help figure out the surgical risk.
Like what specifically?
Okay, so things like PT, PTT, INR, those look at clotting factors. How fast does their blood clot? Super important before you make an incision.
Yeah, definitely want to know about bleeding risk.
For sure. Then a CBC, complete blood count, tells us about red cells, maybe anemia, and white cells, which could signal an infection.
Makes sense.
Sodium and potassium, Na+ and K+ to you, those are critical electrolytes. Imbalances can really affect the heart and muscles, especially under anesthesia.
Right.
ABGs, arterial blood gases. They give us insight into lung function, metabolic status, and of course, a pregnancy test, HCG, is standard procedure.
Got to rule that out.
Absolutely. They also mentioned total protein for nutritional status, and blood glucose is vital, particularly for diabetics, since surgery itself is a major stressor that can mess with sugar levels.
And the basics like heart and lungs?
Yep, ECG for the heart rhythm and electrical activity, and a chest X-ray to check the lungs. Basic but crucial baseline info.
So the guide links these labs directly to figuring out the surgical risk, which affects outcomes. It's about data gathering for safety.
Precisely. It's all about making the surgery as safe as possible by knowing the patient's status inside and out. And another pre-op point the guide stresses is patients on corticosteroids.
Oh, yeah. What about them?
There are specific risks. Corticosteroids can increase blood glucose, so that needs monitoring. They should be taken with food. Long-term use can cause weight gain, swelling.
Right.
And importantly for surgery, they suppress the immune system. That means a higher risk of post-op infection.
That's a big one.
It is. And a major warning. Patients must never just stop taking them abruptly. There's a risk of adrenal crisis, which is life-threatening.
Wow. Okay, that's critical info. So let's move into the OR now, the intraoperative phase. The guide really highlights the circulating nurse here. What's their job?
The circulating nurse is kind of the OR manager and the patient's protector. They're not scrubbed in, not directly handing instruments.
Okay, so they're moving around.
Exactly. They manage the overall flow. They're constantly looking out for the patient's safety because the patient is vulnerable under anesthesia. They monitor the whole team, making sure sterile technique is followed.
Like the eyes and ears.
Precisely. They manage the environment too, temperature, cleanliness, and they're continually assessing the patient throughout the whole procedure.
Okay. Now, the guide mentions a specific, very serious risk here, malignant hyperthermia. MH sounds scary.
It is. Very serious, thankfully rare. It's an inherited muscle disorder triggered by certain anesthesia drugs. High mortality if it's not caught and treated fast.
What actually happens in the body?
It's this intense hypermetabolic state. Specific anesthetics, like succinylcholine, is a common trigger. They cause skeletal muscles to just contract uncontrollably, continuously. This generates a huge amount of heat and metabolic waste products. The body goes haywire, basically.
Who's at higher risk?
The guide mentions patients who are very muscular, maybe have a history of muscle cramps, unexplained fevers in the past, or definitely a family history of MH.
And what are the signs to watch for during surgery?
This is critical. The guide points out an early sign is often tachycardia, a sudden fast heart rate.
Not fever first.
Fever, the really high temperature, that's often a late sign. The tachycardia can be the first clue something's wrong.
Wow. Okay, so fast heart rate is the early warning. How do you treat it?
Immediately stop the triggering anesthetic agents. That's step one. Then, the main treatment is giving dantrolene. It's a muscle relaxant that specifically targets the problem.
Okay.
And then supportive care, actively cooling the patient, giving lots of oxygen. Time is absolutely critical.
And you see the connection, again, anesthesia triggers it, the circulating nurse is monitoring.
Their vigilance for that early sign, like tachycardia, is literally life-saving. They have to spot it.
Makes sense. The guide also mentions hypothermia in the OR, low body temp.
Yeah, it can happen. ORs are often kept cool.
Right.
Patients get cold IV fluids, body cavities might be exposed, and under anesthesia, muscle activity drops so they don't generate as much heat.
So how do they handle that?
Simple stuff mostly. Warm blankets. The key is warming them slowly. Warming up too fast can cause problems like a sudden drop in blood pressure, even shock.
Okay, slow and steady warming. Got it. Let's move to the postoperative phase. Recovery. How often are patients checked right after surgery?
Initially in the PICU, it's intense. Airway and breathing. Checked every 15 minutes.
Every 15? Wow.
Yep. Vitals, cardiovascular status, same thing. Every 15 minutes to start. Then as they stabilize, maybe on the regular floor, it might stretch out to every 4 hours or whatever's needed. But that initial period is very close monitoring.
Makes sense. What about vomiting? That seems common and risky after surgery.
Very risky because of aspiration inhaling vomit. The immediate steps are crucial. Turn the patient's head fully to the side.
Okay.
Lower the head of the bed so gravity helps it drain out, not down.
Right.
And have suction ready just in case you need to clear their airway quickly.
Simple but vital steps. The guide also talks a lot about preventing common complications like DVT blood clots.
Right. Deep vein thrombosis, which can lead to a PE, a pulmonary embolism.
And pneumonia.
Yeah, major risks, often tied to just not moving enough after surgery.
So prevention is key. How?
For DVT and PE, it's all about patient movement. turning frequently in bed, doing leg exercises while they're lying down, and really importantly, early ambulation, getting them up and walking as soon as it's safe.
Moving helps prevent clots. And for pneumonia.
Breathing exercises are the focus there, encouraging coughing, deep breathing, and using that incentive spirometer regularly.
Okay, so the guide directly links immobility to these risks.
Absolutely, which makes those interventions, walking, breathing exercises, absolutely critical, not just nice-to-haves.
Let's talk about that incentive spirometer. We see them all the time.
Yeah.
How does the guide say to use it?
Right. Its purpose is basically to get the patient to take deep breaths, pop open any collapsed air sacs in the lungs, that's atelectasis, and prevent pneumonia.
How do you do it?
Okay, so exhale normally first, then lips tight around the mouthpiece. Inhale slowly and deeply. Try to get the little ball or piston rising. Hold that breath for about 3 seconds.
Okay, hold it.
Then take your lips off and breathe out normally.
And how often?
The recommendation is about 10 times every hour they're awake.
10 times an hour, that's quite a bit.
It is, but it really helps keep the lungs clear. And one more tip. If they need to cough, especially if they had chest or belly surgery, teach them to splint the incision.
How do you do that?
Just hold a pillow, or their hands, firmly over the incision site while they cough. It reduces pain and supports the area.
Good practical advice. One last post-op detail. The first dressing change. Who does that?
That very first look at the wound, taking the initial dressing off, that's the surgeon's job. Nurses monitor it, they might reinforce it if needed, add extra gauze, but the first change is done by the surgeon.
Okay, good clarification. Now, shifting slightly away from the patient journey itself, the guide also touches on the specific role of the LPN, or licensed practical nurse. Especially with IVs, what are their limitations, according to this source?
Yeah, it lists some specific IV tasks that are generally outside the LPN scope, as described here. They typically cannot give IV fibrinolytics or thrombolytics, those clot-busting drugs.
High-risk meds.
Very high risk. Also, administering blood products, or things like volume expanders intravenously is usually restricted. Giving IV moderate sedation or anesthesia, definitely outside the scope.
Okay.
Same for insulin or chemotherapy. These require specialized monitoring. And usually they cannot directly access implanted ports or certain types of central lines.
So clear boundaries there. Okay, let's try to connect the dots now. Stepping back, this guide seems to draw several lines between these different points across the whole perioperative experience.
It really does. You see that direct link between informed consent and overall patient safety, right?
Yeah.
Especially with those pre-op meds. Making sure the patient gets it before they're sedated is fundamental.
Definitely. And then in the OR.
That risk of malignant hyperthermia is tied directly to the anesthesia used, which makes the circulating nurse's vigilance absolutely critical for catching those early signs, like the tachycardia we talked about.
Right, spotting it fast saves lives.
Exactly. Then post-op, you see how those common complications, DVT and pneumonia, are linked straight back to immobility, which is why prevention strategies like movement and breathing and the nursing interventions like walking the patient or using the incentive spirometer aren't just suggestions, they're core to preventing bad outcomes.
And going all the way back to the start.
Those preoperative labs, they aren't just routine. They provide the data to assess the actual surgical risk, which then informs decisions and influences the patient's outcome. It's all interconnected.
It really paints a picture of a system, a process with multiple layers of checks designed to manage risk.
Yeah, a coordinated effort across all phases.
So wrapping up this deep dive, we've walked through this study guide's view on perioperative care, the prep, the OR vigilance, the recovery focus. We've seen the safety checks, the vital team roles.
It's clear there's a lot going on under the surface, even for what seems like routine surgery.
Absolutely. And that brings us to a final thought. You know, considering all these detailed checks and balances we've discussed, verifying consent before meds, checking vitals every 15 minutes right after surgery, the specific rules around who handles certain IV drugs, how does this intense, meticulous process reflect the complexity and the real risks that are being managed every single day to keep patients safe? What does this depth of protocol truly tell us about all that unseen work that goes into healthcare?